So we have my colleague, Dr. Dhivya. She is the Executive Director of Lions Aravind Institute of Community Ophthalmology, where they have a systems approach for everything. And she's going to share how systematically, we can have a good service design to kind of sustainable practice.
Thank you, Dr. Venkatesh. So this talk, before I get into this, I consider myself kind of someone who cares about the environment, but even someone like me was kind of unaware about some important truths about India and just traveling in India. India is contributing to is fourth in contributing to carbon emissions, and our quality of the air, is pretty dismal. So while this is appalling, you may be wondering why I'm talking about transport so much. Because if you look at service design and the amount we as well as our patients travel, it really warrants that we take a hard look at the way we are designing services. When patients come to seek care, it's a long process. There are several steps in this. Now, if we're using an appointment system, you'll know that at every stage, if the patient comes in, he has to make multiple visits because he has to then fix an appointment to see a specialist, he has to fix an appointment for treatment. But if we can provide on-demand care, and if we can complete everything in one visit, then we are able to a great extent, remove a lot of these unnecessary travel for patients. You may not have thought of this as part of ophthalmology, but we are clearly contributing to carbon emissions when we design services differently. Can we rationalize follow-up visits? How many visits do we have patients coming back after cataract surgery? Or to pick up a pair of glasses? Do they need to make multiple visits? All of these contribute to carbon emissions. So can we rationalize this and remove some of these visits? Can more of these visits be made local? So can you have your preliminary examination done closer to the patient's home, say at a primary care center? Today, telemedicine is there. We have no excuse to do this. And similarly, follow-up visits. At our Pondicherry Center and now in many of our other centers, we're having patients who come in from the vision centers. They get surgery. When they are referred for surgery, they come in. All the investigations are done quite early in the morning so that they can get their surgery. They're kept on observation for about 4 to 5 hours. The discharge vision is done right then and they're sent home. They don't come back for a follow-up visit. Where we require them to come for a follow-up visit, we also, if it's not complicated, we have them do it over telemedicine at the vision center, which is closer to their homes. So can we see how we can shift all of this to be more local as much as possible? And we've seen that there is no effect on the outcomes. Slowly, can these even be replaced to something that the patient does within the comfort of their own home? Are we investing on these technological advances? And where possible, can we also look at how we can aggregate transport? I'll talk about that in a bit. So we definitely need to look into how we can go into even more reducing transport for patients. And if you look at our vision centers, this is what I was talking about earlier. These are rented facilities in rural villages. Most of the patients come from within a 10-kilometer radius, so that's the maximum that most of these patients travel to seek care. Every patient pays about 20 rupees. You'll see that they get a comprehensive eye exam. There's a standard clinical protocol, and all patients receive a complete eye examination. These are trained vision technicians, kind of like a equivalent of an optometrist. And depending on the patient's complaints and depending on the patient's age and other history, standard workup is done, like you can see. They undergo IOP testing if they're over 40. They get a BP exam. We're looking for diabetes. Every patient above 30, a fundus examination is also done. And the main thing is we have an electronic medical record. So all these fundus images are now attached to this, and every patient gets to see a doctor through telemedicine. And as he mentioned earlier, the EMR makes all of this possible. The electronic medical record makes all of this possible. The patient, this is live. This is very important. This is a live, there is no waiting period for the doctor to interpret the results. So everything is on demand. So if the patient needs glasses, this is also available. So for all of this, for the service design to really work, it's not just about setting up a vision center. Each of our vision centers sees about, on an average, about 30 patients a day. And this is because the care is comprehensive, it is complete, it is ensure that it is provided in a relevant way and instant. No, it's not about deferring cases, it's not about having the patient wait to see a specialist. Again, it's local for the patient, so they're able to access it. And of course, like anything else, services have to be responsive to the patient's needs and expectations. I want to also share this. I was in rural, this is the most remote place I think I've been to in rural Assam, where there is a cancer care center. This has got nothing to do with eye care, but I just wanted to share that they have an ICU, an intensive care unit, but they can't afford to have intensivists, having super specialty care there, but they have a tele-ICU, where they have cloud physicians who are kind of watching. It's AI-enabled, so the AI is watching the monitors and it alerts the physicians. So these patients are getting excellent intensive care. So you really have super specialty care delivered at remote locations, and it may be even more effective than having them there in person. Greatly reduces the transport burden, and for specialists, they're able to achieve scale, because if you had, rather than having to be there in person. And again, just a small look at our outreach camps, which we do about 3,000 such comprehensive camps in the villages, again, taking care to the people, which means about 12 of our staff would actually travel out to the villages. But then you can, just within reach of their homes, you're able to screen 200 patients, again, reducing the transport burden. And about 60 patients from each of these camps are brought back over for surgery. And again, at these camps, you'll see it's, again, comprehensive. So if, for example, those requiring refraction, a full refractive estimation is done. Those requiring prescriptions are given, the doctor prescribes it there, and the patient is able to get the glasses within about 20 minutes, 20 to 30 minutes. They're able to get custom-made spectacles. Patients pay for it. Patients pay full price. It's not subsidized. It's not free. So no income can actually subsidize some of your other services. We have very high uptake. So we have about 85% uptake on glasses, versus if the patients had to get these glasses on their own. A study that we did show that less than a third of them would actually do it. And again, they would have to travel for it. You'll see in a year, we handle 6 million visits, out of which 1 million is done through teleconsultation. Imagine the amount of carbon emission that's been saved, that has been avoided through this. I just want to now switch to the design of our buildings. I think these spaces are also very important. So many of the Aravind buildings are deliberately designed to reduce the energy consumption. So you'll see the spaces maximize natural ventilation and light. We do not air condition the entire space. We minimize the zones that have AC. The buildings are oriented in such a way so that we're not getting the full sunlight. So they're kind of built in a different direction than the path of the sun. And we also, you'll see many of these buildings have these shades that really cut out the direct sunlight. We have a lot of atriums like this, and we try to bring in some greenery into the building. This is our newest building that we're inaugurating 2 weeks from now. And you can see how much of light is being brought in. A lot of sunlight is being brought in. And none of these spaces that you're seeing right now will be air conditioned. So just these tall atriums, there's enough ventilation here. Only clinics will be air conditioned. And it's very, very comfortable spaces for patients to go around, even in a place like India. And the energy that we use, we try to use clean energy as much as possible. So all our terraces will be filled with the solar panels. This is a drone shot of our Pondicherry hospital. You'll see that the hospital as well as the parking tops are, have the panels, and about 65% of the Pondicherry hospital's consumption comes from its own solar panels. Okay, and about 90% of Aravind runs on clean energy. Some of it comes through its own solar panels, but the rest is bought from energy farms, like solar energy farms or wind farms. So we try to maximize, try to ensure that the energy we consume is clean. And very interestingly, we've kind of shifted to energy efficient appliances. We use energy efficient lights, fans, all the, even our AC plants, all of these have become energy efficient. The company that's done this for us is getting its pay. We don't pay them. Instead, they take a percentage of the difference in the electricity saving that Aravind is making. So you can imagine how much we've actually been spending on energy. If a company can live off of that, can profit out of that. So you'll see all of these lights are changed. Very importantly, water is a huge, we don't think much about water, but water consumption really contributes to pollution in many different ways. And minimizing water usage is one of the things, and you saw that in Dr. Chang's presentation as well. So here we use waterless urinals in the toilets at Aravind. We also have, all of our new centers have the decentralized wastewater treatment plant, which does not use chemicals or is not very energy intensive. In a very natural way that's kind to the environment, it's able to treat the water. So all of these our new facilities are able to treat over 90% of the water that is used in the hospital. The recycled water is used for flushing, for gardening, and it's used for the AC cooling towers. And we also invest in building these rainwater sumps. And the water is also used, the recycled water is used for our gardens, and many of our hospital gardens have award-winning features. With year after year, they get these, their gardens are award-winning. So I just want to conclude saying that when we design for sustainability, we're also finding that our costs are low, our profits are better, and most importantly, we're having a very patient-centered design as well as a people-centered design. So thank you for the opportunity, sir.